Well, the music has stopped, so I think that it's my cue to welcome everybody to our first get-together, alumni get-together in the department of the year. Somebody wave their hand if you can hear me, so I don't. Okay, great. Mark, good to see you. Hope everybody is enjoying the new year. I hope that everyone is healthy and that the challenges of the last several weeks have not been too compelling. I will tell you that the latest data from today is that there are 345 patients who are COVID positive in Jefferson hospitals. That's not necessarily because they're in the hospital with COVID, but they are COVID positive, which sounds pretty terrible. But I will also tell you that 3 weeks ago, that number was 1,441. So that's over 1,000 decrease in the past several weeks. And there are less than 50 people in ICU. So I hope all of you are staying healthy and wish you all the best. Tonight, we have one of our relatively newer faculty members, which is different from a new faculty member. Karolynn Echols is our speaker this evening. And Karolynn is our director of female pelvic medicine and reconstructive surgery. She was recruited to our department in 2016 to take on that role. And her background is actually quite unique for a lot of reasons, one of them being that she is also trained and certified in integrative medicine and acupuncture, and leads a team, including Renita Ross and others, who have a great deal of expertise and are seeing an increasing number of patients with chronic pain conditions, with vulvar conditions, and with sexual dysfunction. So she wears a lot of hats in the department and in the organization. She is remarkably insightful about so many things that I care about. And I want to introduce her this evening. Her topic is Integrative Gynecology in the 21st Century. Really, honest to goodness, it's not voodoo medicine. So, Karolynn, thank you for, we hope to have 30 people tonight, which is our biggest alumni gathering yet. Just as an FYI, Karolynn, we have some people who are with us most every time. Lockwood Young, who's in the upper right corner for me, is the farthest away. He's in Hawaii, unless he's come to the mainland for some reason.
Oh, nice.
And he'd love to host you anytime you want to come.
I'm coming.
With the, Lockwood is about 17
don't say
degrees
that.
here. So I'm going to turn this over to Karolynn. I do have to apologize in advance. I had a family issue come up, and I'm going to have to leave a little early tonight. But know that I will be with you even as a program ends. So welcome to everyone. So good to see the family.
Thank you, Dr. Slaw, for that introduction. Welcome, ladies and gentlemen. I call this topic integrative gynecology, although I'm trying to develop this subspecialty integrative urogyne, just because I do some GYN as far as integrative medicine. And I got into it because my dad, who has recently passed, in 2015, but he was diagnosed in 2005 with, liver hepatocellular carcinoma. And as you all know or don't know, it's, the death rate is really high in 2 years. So I went seeking for something to try to help him. And besides, conventional medicine. And I think that, me doing some of the things that helped him, he survived for about 12 years after a liver transplant. So I decided to pursue this because I think that in healthcare, remember that, the pharmacological stuff that we have, even the synthetic, but the non-synthetic, it comes from plants as well. So I think we can do better. And so that's why I'm seeking this and seeking to be an expert in this field. So it's not voodoo medicine. It does work. And there is some evidence base on some of the things. And the one thing that we should know is a lot of patients come in on these nutraceuticals, doing some of these things, and some of it can be dangerous. So we should know at least a little bit to try to help them out. Now I'm gonna have to say next slide because I'm actually on my iPad today because my internet for some reason is shoddy. So these are my disclosures, but I have no relevant disclosures for this talk. Next slide. So by the end, you should be able to define what integrative medicine is and understand how it relates to conventional medicine, and then discuss how to incorporate the basics into the practice. I know it's a little bit difficult because we all have issues with time, um, but using a case-based approach, we can actually try to help some of the common issues that we encounter, and then understand the appropriate treatment approaches that consider integrative modalities and address the individual patient. Next slide. So when we define integrative medicine, over 30% of adults and over 12% of children actually use this. And the number has actually gotten larger as we move on in time. Now, if it's non-mainstream in practice and it's used together with conventional medicine, it's considered complementary medicine. If it's just non-mainstream, it's considered alternative. We usually don't do true alternative medicine. There is a role for conventional medicine, and there's a role for alternative. And sometimes what happens is when you put them together, actually a lot of times it becomes adjunctive. Next slide. So where I train, which is now called the Andrew Weil Center for Integrative Medicine, it's a healing-oriented medicine that takes into account the whole person. Remember, stress can kill you. So, you have body, mind, and spirit. You want to include all aspects of the lifestyle, support, etc. And it emphasizes that relationship and makes use of all appropriate therapies. Next slide. So this is some old data. I was looking for some of the new data at the Health and Wellness Trends database, and I have some of it coming, but this is from 2002 and has gotten even bigger. But 50%, even like 20 to 50% of people, period, use some sort of alternative medicine or integrative medicine, vitamins, nutraceuticals, herbal supplements. The biggest, of course, being calcium, which we do prescribe to our postmenopausal women. Vitamin C, especially for the urinary tract infections, B12, B complex, etc. Folic acid in pregnancy. Next slide. As you look for the manual therapies, Tai Chi, relaxation techniques such as meditation works for different modalities and different issues such as depression and anxiety, yoga, massage, diet. Next slide. So the 10 most common approaches in young adults, this is from 2012, include natural products, nutraceuticals, what they call supplements, herbals. Then you have kind of the manual, like mindfulness, deep breathing, meditation, yoga. There's osteopathic manipulation, massage. Diet is starting to surpass a lot of these. Homeopathy is when like treats like, and I'll get into that later. And then there's guided imagery, which is part of mindfulness as well. Next slide. So I'm going to start off with the clinical scenario. I'm sure you guys probably seen this in your practice, hopefully. 34-year-old with severe dysmenorrhea since menarche. The pelvic pain progressed to constant pain and dyspareunia. Oral contraceptives alleviated her symptoms up until 3 years prior, and she underwent a laparoscopic resection of moderate endometriosis. After failing conservative therapies, a repeat laparoscopy is performed, and on repeat, mild endometriosis was found, and it was meticulously resected again. And 3 months later, she continues to have the same pain. Why did she not improve? Is there still persistent endometriosis? Was it the wrong treatment or diagnosis? Is she malingering or have other reasons for her pain? So endometriosis can be present, with chronic pelvic pain, but only 18% of patients have endometriosis as the only reason for pain. And that's key. Unfortunately, a person can have more than one problem at the same time. Next slide. So just real briefly, chronic pain is present for a minimum of 3 months. It can be constant or intermittent, and the quality of life is affected negatively. And it involves, inflammation, and then you've got this active sensory pathway that then creates more recruitment of nerve cells and then central sensitization. So they just have pain pretty much in a lot of places. And then you have major or many painful conditions that are out there that equal, that are in addition to endometriosis. So you can have vulvodynia, you can have irritable bowel, chronic migraines, fibromyalgias, etc. So a lot of these patients actually come in with these comorbidities. Next slide. 1 in 7 women, chronic pelvic pain, and 10% of all referrals to the gynecologist. And I think that number is just underinflated. $22 billion. It's a $22 billion industry, and it's going to become more and more. And up to 50% of these patients have been abused. It is really difficult to treat these patients. It's a multidisciplinary approach. It's needed. And of course, there's morbidity and mortality that's involved. And so it's really important that we get it right. Next slide. So just consider all the different reasons for chronic pelvic pain. I'm not going to belabor this anymore, but not only gynecological, but you have to think about psychological, urological, musculoskeletal, GI, etc. Next slide. So basically what happens is the patient experiences pain for a long period of time, and then the brain processes this, and then it perceives it differently, and then you get this amplification of pain and more recruitment of nerve cells, and then continued pain, and then it's just a cycle. So how do we treat the woman with refractory chronic pelvic pain? Next slide. Very busy. I meant to put it up there like this. There are so many different etiologies, and 86% of these patients have more than one reason for their pain. Next slide. Now, when it comes to endometriosis, there's really this quadruplet. In the middle, pelvic floor dysfunction. I'm not a big fan of that term because it's so generalized, but a lot of these patients will have a combination of endometriosis or irritable bowel or bladder pain syndrome. And all of these, or one of these, will lead to the middle pelvic floor dysfunction, which is the generalized term. Next slide. So your initial visit is the best time to collect information. You want to watch her walk into the room, watch her sit down, allocate time to get the history and for the patient to express themselves. And it can be time consuming, so you can use questionnaires, you can use your support staff to help you out. This may be therapeutic as well, because having the patient talk it out does help, and it's more of a biofeedback. And you may need to divide this into several visits, including telehealth. Next slide. The paperwork, you have the MAR nurse review with the patient, chief complaint, the history, the questionnaires, and more importantly, the goals and expectations. Fully clothed and in the office rather than exam room if you can, and even telehealth does help. Definitely use review systems to obtain that detailed history of organ systems and to get your differential diagnosis. So when it comes to pain, the pain catastrophic scale, I use actually all the time, because what happens is this was developed in Canada as far as researching how patients think about pain. And so if someone comes into the office and saying nothing's going to help, they're really going to need kind of mental and therapy to actually help them see what's going on with them in order for treatment to try to make a dent into what's going on. When they score above a 35, and if you take a look at the next slide, this is the questionnaire. If they score above a 35, then basically it shows that pretty much any treatment that you try to offer them is really not going to help them. So you have to have them get over that and the fact that they do have pain in order for treatment to make a difference. Next slide. You have to consider other issues that are going on with the patient, like sleep disruptions. They can't have fun and exercising. What's the impact on family and relationships, daily activities? What's been tried? What has worked and then stopped working? Multiple surgeries actually do raise a red flag. And basically what happens is these patients come in wanting another surgery because it can relieve their pain. They think it can relieve their pain. And you may need to separate, if the partner comes and answers all the questions, you may need to separate them. And you want to watch that body language as well, because remember, close to 50% can be abused as far as this diagnosis is concerned. Next slide. So I'm not going to belabor this either, but just the current status of their symptoms, looking at character, radiation, associated events, duration, and intensity. Next slide. And then, of course, the comorbidities, and this fibromyalgias, chronic fatigue syndrome, lupus, and any association with depression, anxiety, or panic disorders. Your past medical history is important. Childhood history of constipation or frequent urinary tract infections, any bleeding or irritation. Mental health is important. A detailed menstrual and sexual history. And that's where the questionnaires may be helpful. And then, of course, abuse. And then remember your surgical OB history and GYN. What supplements are they on? What medications are they on? Are they on vitamin D? Vitamin D disorders can actually contribute to pelvic floor disorders. Deficiency can contribute to pelvic floor disorders. Statins can cause depletion of CoQ10, which can cause musculoskeletal pain. Proton pump inhibitors decrease magnesium levels. Have they been on that for a long period of time? Diabetics on metformin. B12 deficiency causes neuropathy. So you want to consider the deficiency in diabetics, even vegetarians. And remember, postmenopausal women get GI atrophy and they can't absorb like they should. You want to consider patients' allergies, sensitivities, because that also slows digestion, and then they can't digest and they become quote unquote malnourished, which could be a problem. Next slide. Then the sequence of exam, of course, you want to watch them first. Look at the back, look at the musculoskeletal system. Are there any discrepancies? Acquired leg discrepancies can cause pelvic pain as well. Skin, there's a condition where you look at the skin where they actually use a lot of heat until they get this rash. And that also gives you a clue as to where their pain may be. I put HARA diagnosis because that's from acupuncture, but that is essentially part of Eastern medicine where constitutional symptoms, you want to clear that first before you do treatment. And then, you have your pelvic exam. So, vulva, vagina, cervix, rectum, bimanual. Speculum is last. And then I actually look at the ear just because that actually gives me a clue sometimes to helping me diagnose the patient as far as auricular acupuncture. Next slide. For your abdominal wall, gentle finger pressure, your Carnot sign essentially is when you place pressure on the abdomen, they have pain, but then when they sit up, they even have more pain. Don't forget your ilioinguinal nerve, that groin pain as well. Scars are important. For me, what happens with scars, it can actually cross the meridians. And remember, with acupuncture, we're made of force fields. And so with energy, what happens is if you clear that energy, and I actually do inject scars to try to help the treatment. And it does help, especially with the patients who I'm treating for pain. Next slide. And this is just more of the acupuncture diagnosis for the HARA. It's just basically you're looking at the meridians and seeing which meridians are causing them issues. And you're doing an exam based on that. Next slide. You look at the vulva. Don't forget the dermatomes, your reflexes, previous traumas or scars, and you want to see what their muscle strength is as well. Next slide. And then you examine, the vagina. So single digit exam, you want to examine the paracervical tissues, the lateral vaginal sidewalls, the muscles, including the levator ani, piriformis, obturator. Next slide. And then without the abdominal hand, you palpate the urethra, bladder base to see if there's any tenderness, cervical emotional tenderness, the ligaments, lateral vaginal fornices as well. Next slide. And then you have your bimanual. Don't forget your rectovaginal exam, which is really important. And you want to feel for nodules as far as the uterosacral ligaments, or even no motility when it comes to the uterus. Next slide. Your speculum exam may not be possible at this point. I always use a very small speculum. Sometimes you have to use a pediatric. You really don't want to use that until if they have spasms, you want to address that first. And then you want to take a look to see if there's any lesions or infections or evidence of infection. Next slide. Now, as far as the labs, I'll send a vitamin D level just because there are studies that look at vitamin D and pelvic floor disorders, such as incontinence and even pain. And just for definition, insufficiency is between 21 to 29, over 30 is normal, but I like the levels in about the 50 to 75 range. Deficiency would be less than 20. And then, you want to screen for especially those patients who are melanin rich or have skin covering, obesity or gastric bypass, chronic kidney disease, even the pelvic floor disorders or osteopenia, porosis, or perimenopausal women. Your vitamin B12, because that can cause neuropathies. Probably 50% of the population is deficient in magnesium. Magnesium is intracellular. So if you see a magnesium level, just a regular magnesium that may be in the low normal range, their RBC magnesium level may be lower. If you think that there's something going on, and I know we don't use C-reactive protein or SED rates for diagnosis anymore, but you want to see if there's inflammation. And if you have a question, if it comes back negative, then you may be looking at something that's constitutional or even psychological. But if it comes back that it's some sort of inflammation, if it's higher, then we definitely need to look for a diagnosis. Next slide. Don't forget your imaging diagnostic tests, including cystoscopy. You may need to send it out if you don't do cystoscopy in your practice. Next slide. Now, when it comes to just in general, and inflammation is basically the root of all evil, right? And so diet is where we get inflammation from mostly. Nutrition and exercise are very important. So a consultation is great to recommend. A mental health consultation as well, especially if they score high on the PCS. Now, the things to avoid, of course, a high fructose corn syrup, because there's a lot of studies that look at that causing fatty liver. Carrageenan actually has been taken out of organic foods because it's an inflammatory agent and a possible carcinogen. Acrolein, there's a question about barbecue and grill. I know you guys are frowning. It's inadequate evidence. It's not classified as carcinogenic, but they're starting to look at that more. Next slide. Your anti-inflammatory diet by Dr. Weil or the Mediterranean diet, it's similar. They would have to be on that for a good 8 months to a year in order to see the changes, but that's something to start the patient out on, at least to have nutritional consult for that. And so it's more omega-3, less omega-6s, more fish, lean meat, less pasta, more whole grains as opposed to, other grains or sugar, and definitely regular moderate exercise. Next slide. So with your Mediterranean diet, the studies actually looked at the different inflammatory markers, and there's a lot of studies out there that show decreased in these levels. It takes time to have to reduce these levels, and so starting them is just the beginning. Of course, you want to add treatment, and sometimes you want to add the conventional treatment, but definitely a Mediterranean diet is doable and something that can be controlled by the patient. And yeah, there's some cheat days, etc., but definitely this is something that can be done. It's not really hard to do. Things are yummy. And so a nutritional consult for this helps. I mean, look at the red wine. It increases HDL. Of course, 1 glass for women and 2 glasses for men. That's the recommended daily limit. If you do more than that, then that causes more harm. Next slide. There was a 4-year prospective study looking at about 10,000 individuals who adhered to the Mediterranean style diet, and 42% reduction in risk of depression. And so those patients who do come in, which we see depression and anxiety, this is something to start. Next slide. I send levels to define whether they're insufficient or deficient because it is associated with pelvic floor disorders. And I do replace by 50,000 units a week for 12 weeks and then check a vitamin D level to see if they're in the right, level. And then I'll start 1,000 units a day and then send them back to the primary care for them to keep managing it. Next slide. With magnesium, 50% of the population consumes less than the recommended daily allowance. And it's associated, deficiencies associated with metabolic syndrome, colon cancer, seizures, arrhythmias, muscle spasms. And in 2011, the FDA issued a MediWatch warning of long-term proton pump inhibitors and low mag levels. So those patients who are on, ranitidine, Pepcid, et cetera, magnesium level may be beneficial, especially if they come in with pain. And if they do, and if they have issues with sleeping or even bladder spasms, recurrent urinary tract infections, constipation, remember magnesium is a treatment for migraines. You want to make sure their kidney function is normal, but 400 to 600 milligrams at bedtime. I use magnesium glycinate or gluconate or chelated magnesium because it doesn't really affect your GI tract that much. It doesn't cause cramping. Epsom salt baths, but it does alkalinize the urine. It helps with sleep, and it helps, of course, with constipation. Next slide. Omega-3 fish oil is a natural anti-inflammatory. Now, the one thing is you want to make sure that the epipoic acid and dicohexo, I can never pronounce it, DHA ratio is 3:2. If the patient is vegetarian, then it's alpha-linoleic acid, which is in flaxseed, walnuts, soybeans, but it lowers the triglycerides. It can actually elevate the HDL, which is great. It boosts the effectiveness of anti-inflammatory. So if they're always on constant like Celebrex or Advil, Aleve, this definitely helps. And if you give under 4 grams daily or 1 gram recommended daily allowance of 1 gram, you're not going to get an increase in bleeding. The one thing that I'm looking at is a natural ERAS protocol for enhanced recovery after surgery. And this is one of the things that I would like to add, as well as I'm looking at magnesium levels right now. It is protective against Alzheimer's and dementia as well. Next slide. And then you look at your probiotics. So there's a bunch studied for interstitial cystitis and that microbiome, irritable bowel syndrome with bifidobacterium, and then treatment for recurrent urinary tract infections. They looked at Lactobacilli crispatus, as well as the Reuteria rhamnosus. The bottom 2 were topical, but I actually do use it orally to help my patients with recurrent urinary tract infection, and it has been successful, but there definitely needs to be more studies out there. Next slide. And then, for endometriosis, don't forget the endocrine or hormonal disruptors, such as BPA, phthalates, triclosan, which is in the hospital. But basically, it's been affiliated with learning disabilities, fertility issues, even birth defects. And so there was one story one of my colleagues told me about where a patient would present with abdominal pain, and they just could not figure out. They did the complete workup. I mean, she had everything basically except for a PET scan. There was one thing in her environment. She was making tea from these plastic kind of tea makers that boil water. Well, they decided to eliminate it. Her abdominal pain went away. And then they added it back and it came back. So that's the culprit. And that's really interesting because, that those are one of the things. They boiled plastics and putting plastic in freezers. That can also cause issues, and it's an endocrine disruptor as well. Next slide. And this is what I do for pain. So they actually in Maryland, the state of Maryland, this is actually a treatment for opioid abuse. I'm kind of hoping they'll bring it to Pennsylvania. There needs to be more research needed, but there are 5 points in the ear that correspond to kind of the pain meridian. And I actually do that in my office when patients who come in with like acute pain or interstitial cystitis flares. You place needles based on their scale from 0 to 10, and you want to get them from their highest score down to a 0 or 1. You go from one ear to the other. You can actually place needles side to side, depending on if you have a 2 or 3 point drop. And if you get to a 1, you don't want to put any more needles in there because that can actually increase their pain. They can wear these, they're called ASP needles. They're very short needles. They can wear them for about 4 days, and then they kind of come out, and they'll come back a couple of weeks later for more pain control. But it does work in a lot of patients, and we're actually getting ready to publish some data on that. Next slide. Low dose naltrexone is another thing that I use. Low dose naltrexone are higher doses, of course, for opioid use, but in low doses, it increases, the endogenous endorphins, enhances immune function, it decreases inflammation, and it can actually really help with patients' pain. I use that as a little bit of a last resort before sending them to pain management, because this is something that's made by the compounding pharmacy in such a small dose, 1.5 to 3 milligrams, and then you can increase it to 6, but that's all I would go. I give it to them in the morning because it can cause insomnia. And it's funny because a lot of the patients come back and they have clarity. Next slide. So it blocks the opioid growth factor. It produces the beta endorphins. It's been studied in fibromyalgia and autoimmune disease, as well as rheumatoid and irritable bowel. They use it for opioid abuse. And I've gone up to 6 milligrams, but you can go 1.5 daily to 3, then you increase to 4.5 and then to 6. And I usually do it, increase it every couple of weeks if it doesn't work. Next slide. Now for depression and anxiety, these are all the different types you'll see. Of course, if you have access to a mental health professional, very important to get their advice and potential treatment options. Next slide. But some of the associated disease states include vitamin B12 deficiency, so you're diabetics on metformin, lead toxicity, some pesticide exposures. There can be patients that are sensitive to estrogen. Of course, steroids, caffeine, and even beta agonists can be associated. Next slide. As far as treatment, and in the alternative is yoga. There's some studies that look at yoga in the reduction of stress and anxiety, and definitely important, especially for pain and how to cope with it. The study in 2005 is very small sample size, 3 months of yoga classes twice weekly, saw significant improvements on the outcomes, the questionnaires. There's a couple other studies that add stress and anxiety to pain that actually look at, and there's an improvement as far as using hatha yoga. And so yoga is one of the things that can help these patients deal with their condition, as well as deal with the stress and anxiety they get from this condition, chronic pelvic pain. Next slide. Second scenario, 31-year-old, para 1001, 6-month history of lower abdominal pressure and discomfort, has more superficial than deep pain with intercourse, constipation relieved by decreased activity, had an OB history significant for long labor 8 months prior to her presentation, vaginal delivery, and then had a tear that was repaired. And on physical exam, there was significant levator ani tenderness. Next slide. Pelvic floor dysfunction. So it's also known as all of these conditions. So spasm, coccydynia, vaginismus, shortened pelvic floor, hypertonic pelvic floor. Next slide. The only diagnosis that if any of you do Botox injections into the vagina or even trigger points is myalgia of the pelvic floor. If you use high tone pelvic floor, unfortunately, although that's the correct diagnosis, insurance may not pay for it. Now, of the chronic pelvic pain patients, that includes endometriosis, about 22% had levator ani tenderness, and over 10% had piriformis muscle tenderness. And over the next almost 20 years, pelvic floor dysfunction is predicted to increase by 1/3, with greater than close to 2 million patient visits. So we will, if you haven't seen it now, you will see it. Next patient, next slide. So again, pelvic floor dysfunction can involve any compartments, the anterior, the middle, or the posterior. And the pelvic floor, it's storage of urine and feces. So if there's an issue with evacuation, you want to look at that as well. and then also the support of the organs and sexual function. Next slide. So the presenting symptoms can be dyspareunia or pain with a tampon, painful orgasm, pain after sex, low back pain, which is the only thing that's acupuncture is covered by insurance for low back pain. Pain with sitting or prolonged standing, bladder or bowel symptoms. And then that's where you see that rash in the abdomen. They use heating pads to ease the pain. And so that can give you a clue to their diagnosis. Next slide. We don't know the etiology. There's a bunch of things that can contribute to it, but some of the theories include a metabolic imbalance. So nutrition is really important. Of course, that central sensitization, and then it's been linked to prior surgeries, endometriosis, sexual abuse. Again, here's the anxiety. There's been some association from childhood problems. It's 10 times higher in patients who had bladder problems as a child, or 7% in children with elimination disorders. As an adult, they've had holding patterns and sexual abuse. And so these are the things that can contribute. And that means that some of these patients will definitely, and I think all of them would need, if you have access, would need mental health professional, even if it's just for one consultation, to kind of deal with these issues. Next slide. So you've got all these pain syndromes that then contribute to the pelvic floor. And so it can cause dysfunction and then all the symptoms that come along with it. So the key is to find what is causing this, or if there are several things, what are the other things that you can treat so that it can treat the pelvic floor dysfunction. Next slide. So again, you want to treat perpetuating factors as well, the pelvic floor, and then you want to identify those underlying causes, such as those named above. Next slide. So as far as after your exam and your history and physical, et cetera, I won't belabor that. Pelvic floor physical therapy does trigger point releases, even massage internally, stretching, myofascial release. So it's close to trigger point releases. And if you have a question as to any of the physical therapists in the area that actually specialize in this, the website is www.apta.org. But the expectation is improvement in the severity and also the bowel, bladder, and sexual symptoms. And so questionnaires will help that to have patients see their objective improvement, but then it's important that their quality of life is improved as well. Next slide. Now, PT is also combined with manual manipulation, such as biofeedback or electrical stimulation, even dry needling, where essentially it's that acupuncture needle that actually instills a spasm until the muscle tires out, and that can help as well. Next slide. Your cognitive behavioral therapy helps, and your relaxation techniques as far as psychological services. Next slide. And then your medical treatments include vaginal Valium, bunch of studies out there for that. Small sample size, but it has showed improvement. There's one randomized controlled trial that didn't show any difference. I have used it in my practice. I started off with 5 and I have increased to 10. Only do it maximum every other. And you can actually have them place it in the rectum as well, which actually absorbs a lot better because of the vessels. There are more vessels in the rectum. And I find in a lot of patients, there is a difference, especially when the cause is just specifically the spasm and they're just spasming for whatever reason. Is it CoQ10 deficiency? Is it that they've pulled their hip muscle and now they're spasming? Things like that. Belladonna is an anticholinergic, which could help as well. It helps to relax the muscles too. Your non-steroidals, don't forget to add omega-3 fish oil, which will help. Your muscle relaxers, such as, I'd rather do Flexeril than some of the other muscle relaxants. Although I try to avoid some of the addictive medications, I will try the alternative therapies first. Neuromodulation, such as sacral neuromodulation or pudendal, lidocaine, especially for the outside. But the adjunctive treatment, such as acupuncture and nutraceuticals, you don't want to use it in isolation. You start with that first, and if they get relief, beautiful. But then you want to add diet, and you could potentially add some of this conventional therapy if you need to. Next slide. Don't forget CoQ10. So a lot of patients are on statins for, cholesterol. And so it depletes CoQ10 enzyme, and they get this statin-induced myopathy. They looked at almost 600 patients and replaced them. And CoQ10 supplementation could potentially help these patients. So if I have somebody that comes in as on a statin and has these issues, I will automatically have them placed on CoQ10. And you could start off with 100, excuse me, and then you could increase to 200 milligrams a day. Next slide. Excuse me. I do Botox of the muscle. It lasts for 3 to 4 months, sometimes a little longer. I also add dry needling. I'm trying to find my water. Excuse me for 1 second. Next slide. These are the studies looking at Botox, dysmenorrhea. It takes about 10 days to notice an effect. And actually, I've been dry needling, and I'm about to publish that as well, before I inject the Botox. And I find that I delay their symptoms from coming back for at least about 5 to 6 months. Next slide. Then you could do this under ultrasound guidance. We have a interventional radiologist who actually takes a look, because the pelvic floor is not just elevator ani, piriformis, obturator, internus. You could have some hip issues, labral tears, even ilioinguinal neuropathies that you can see on ultrasound or even MRI. And that's what they inject to try to address that myofascial pain. So what happens is the patient has pain and then clamps or contracts their muscles in order to kind of get rid of the pain, or the pelvic tries to adjust to try to help them combat the pain. And then they get more pain based on the contracted muscle. So you want to address what caused the pain first, and then address the muscle, because if you address the muscle first, then it can actually put them into a downhill spiral because the support mechanism is no longer there. Next slide. Pudendal neuralgia is something that I'm starting to see a lot more of. Next slide. And it's pain in one or more areas innervated by the pudendal nerve, such as the rectum, urethra, or genital area. They can actually have bladder issues from this. Next slide. Their symptoms can include burning or a feeling of a lump in the vagina, a pinching sensation, even constipation, painful intercourse, even genital arousal disorder. Next slide. So the exam is really important. You want to eliminate the other factors. An MRI, CAT scan can actually help. Physical therapy, including myofascial release, will help. And then you've got sometimes electrical physiologic testing. I don't use that much because pudendal nerve motor latency testing, in the scheme of things, you want to identify what's wrong with the patient. So you want to look at that. But if it's a generalized, there's no control for the results of this test. And so you actually want to individualize it if you use this modality. Next slide. So if you take a look, and I don't have a cursor here, but where the arrows are, you have a thickness on the patient's left side as opposed to the normal on the right side. And you can actually see that on the MRI, and it can be seen on ultrasound as well. Next slide. And that can be injected. So your treatments definitely include lifestyle changes. So if they're sitting and they have pain after they sit for long periods of time, sitting on a pillow, standing up to stretch, a standing desk, Some of the nutraceuticals and natural anti-inflammatories. The one thing I didn't put a slide on is turmeric, which needs to have either pepper or a fatty meal to digest in order for it to work in other areas in the GI tract. Massage therapy, Botox, pudendal nerve blocks, neuromodulation, and definitely pain management if you really need them to help. Some of the good studies on pulse frequency radioablation. And then I'm starting to do more regenerative therapies by injecting allograft into the pudendal nerve, which has been showing some promise with these patients. Next slide. This is CT guided. And you take a look at the thickened pudendal nerve on the right side versus the left. I'm sorry, the left side versus the right, where the arrow is. Next slide. Again, radio frequency. There's a case series from Canada. They only had 7 patients, but this may be effective and safe, especially when conservative management doesn't work. Next slide. And it certainly beats the opioid treatment, especially nowadays with opioid abuse and overdose. Again, another study, 77 women. It's effective 3 months following the surgery, following the procedure. Next slide. And then some of the ongoing research, such as this is on label, RIO, which is amniotic, it's kind of microRNAs from amniotic fluid. And what happens is they see growth factors and fibronectin, which then reduces inflammation and helps the nerve to regenerate and heal. I've done probably about 200 cases, and we still have to evaluate the data, but anecdotally, probably about 80% have improved. They do come back between 3 months to a year to get another injection. But it has shown promise. And then PRP, which is platelet-rich plasma, has also been demonstrated to be effective. They use it in the ortho literature, but we're starting to use it in the GYN literature. And it activates the stem cells in the area of injecting. Your peripheral nerve stimulation, and then of course the integrated medicines such as acupuncture, manual therapy, cognitive behavioral therapy. And never forget nutrition. Next slide. Third scenario, 53-year-old advertising agent, Samantha, pun intended, para zero, who suffers from difficulty sleeping, intense hot flashes, and night sweats for the past year. Her last period was at age 52. She has no significant GYN history. Her high blood pressure is well controlled on amlodipine. She has never had surgery, is currently sexually active, but has a decrease in desire, which she says is unlike her. She has some vaginal dryness and uses topical estrogen for relief. And although she's considering HRT, she really wants some information on some of the alternative regimens for her symptoms. Next slide. Menopause. So I'm just going to go over some of the treatment options that are out there. Alternatively, such as hypnosis has shown a 70% reduction in hot flashes. This is one of the studies, but there are several studies out there. Cognitive behavioral therapy, which includes meditation and actually guided imagery. And they talk about positive treatment effect. We don't exactly know what that means. When I reviewed the study, it doesn't really say what they mean by positive treatment. CBT is not gonna hurt the patient, so it's something to try, but they do need more studies on this. Biofeedback has been shown to work, and there's numerous studies on that, and relaxation training. Again, mind-body stress reduction, such as meditation and yoga, has improved quality of life, but no improvement in symptoms, which is interesting. Now, your aromatherapy includes essential oils, and there's inhalation, which is a diffuser, and then there's oral, which I don't really use, and then there's topical. You have to be careful with topical because you have to dilute the oil. If you don't, you can burn the patient. Lavender is one of the most studied, and it has reduced or increased sleep and reduced hot flashes 50-1. Aromatherapy, no, go back to, sorry. Using it with massage also is more beneficial than using it by itself. And there are several studies there. Now, next slide. Black cohosh is something that I've used, but you want to only give it for 6 weeks, and then they need a break for a couple of weeks. There definitely needs more randomized controlled trials. And you want to make sure that you make sure they take a break, because it can cause hepatotoxicity. Some of the sensitivities are GI issues and rash, but it has helped patients with hot flashes. While YAM works, of course, it has some estrogen properties in it, a 70% reduction in symptoms. Maca root, which is from South America, limited evidence, doesn't hurt, but that's something to also talk to the patient about. Then you have your phytoestrogens. I use flaxseed oil, which has lignans, which is kind of estrogenic, soy as well, but you really only want to stay under 25 grams a day. Red clover and hops. Red clover is the one that has the better study in it as far as reducing hot flashes. So it doesn't reduce the frequency, but it reduces the intensity of the hot flash. And hops is, of course, what's in beer. And the reason why hops works is because it helps you to sleep. Vitamin E and evening primrose oil lack evidence, and so I don't use those in my practice. Next slide. Reflexology is essentially, it can be done on the foot, it can be done in the ear and the scalp. It basically, there's points that you put pressure on corresponding to the body. And it has been shown some promise, but there needs to be more studies. Same thing with acupuncture. And with homeopathy, where like cures like, so you want to give the disease essentially in like tiny dilution in order to help. And shows promise, but there still needs to be more studies out there to say that it definitely is successful. Next slide. So the fourth scenario, Jenny is a 30-year-old, this is the last one, postgraduate student who suffers from frequent urinary tract infections for the past 3 years. She gets burning with urination after intercourse, which lasts until she's treated. She worries about taking so many antibiotics. And it seems like every time she goes home for vacation and has sex with her boyfriend, she gets another UTI. After taking the course of antibiotics, she reports she gets a yeast infection, which is also very uncomfortable, and wants to know what she can do to prevent these infections and whether she can avoid antibiotics to do so. Next slide. So again, 30% UTIs in lifetime in women. It increases with age. And usually the recurrence is secondary to reinfection, but billions of dollars are spent annually. Next slide. You have your recurrence, which is 2 infections within 6 months or 3 in a year, and it needs to be separated by at least 2 weeks, or you have documented success of treatment for the first infection. Relapse is when the infecting strain is the same and occurs within 2 weeks of the completion of the antibiotics. And the reinfection is recurrence caused by a different strain after 2 weeks of treatment. The majority is reinfection. Since you still have, in the stool, there is the strain there. It just recolonizes the vagina and then the urethra and bladder. Next slide. So your risk factors include diabetes, increase in frequency of sex, previous history, catheters, kidney stones, congenital issues, and abnormal anatomy. Next slide. E. coli is the most common. Staph saprophyticus is the second most common. Proteus is usually from kidney. There's an issue. There may be an issue with kidney stones. You got Pseudomonas, which is usually secondary to instrumentation. If you have yeast, then you need to look for immunocompromised issues. Next slide. Again, your primary criteria is 10 to the 5 colony forming units, the bacteria, and 1 sign of cystitis. The alternative is 2 signs with no other cause and a dip that shows leukocyte esterase or nitrites, or you see on a UA with no epithelial cells, white blood cells. We don't do, I don't do gram stains anymore, but that's one of the criteria. Next slide. If you see leukocyte esterase or nitrites and there's no epithelial cells, it's 75% sensitive, so it's not that great. If it's negative, it's a little better, but it definitely adds little clinically to symptomatic patients, but it's good with the patients that, you know, you have worsening frequency and overactive bladder, they've had normal urines up until now. This may be a urinary tract infection in these patients. Next slide. Your urine analysis detects the bacteria, white blood cells and red blood cells, microscopic hematuria, and the bacteria are insensitive and they're often negative in urinary tract infections. So a UA is really not helpful, although if you see nitrites, as long as they're not on peridium, which can actually give you a positive nitrite on a dip, it's not really helpful in diagnosing UTI. That's why I send a culture. And a clean catch is extremely important if they can do it. A lot of my patients can't, so I will straight cath them. Next slide. The culture is the gold standard. It's usually, you know, good for bacterial presence and susceptibility, which is important because we have resistance in our area, and there's resistance to antibiotics in a lot of areas like Bactrim, Macrodantin. Since we give a lot of Cipro, no, I don't, but you know, a lot of Cipro and Levaquin is handing out like candy. Resistance is starting to come up as well for that. Next slide. Antibiotics. Oh, next slide. So you've got your standard approach, but you keep giving antibiotics, they're going to get resistance. And so we have to figure out something that can help them, that we're not contributing to resistance. Next slide. So there's one study looking at just spontaneous resolution of symptoms, and they found that up to 42% of women will have spontaneous resolution. So drink water, avoid citrus, rarely progresses to infection of the kidneys. And apparently the risks and benefits equal that treatment for a simple UTI. There was a study in 2012, one of the bigger ones, 137 women, and a third agreed to delay antibiotic treatment, and 71% had clinical improvement. So that's kind of significant. Next slide. So lactobacilli kind of helps because it secretes hydrogen peroxide, it kills E. coli. So if you have a decrease in lactobacilli, then E. coli can grow and you have an increased risk of recurrent UTI. And that's what happens when you have a pH in the vagina that's basic. Lactobacilli rhamnosus and reuteri, they've studied that as far as an effective treatment in UTI, and there's a few studies there. They treated with Bactrim versus these two, and have gotten, essentially, they showed the same success rate. And so there's a couple of preparations on the market. Next slide. Femdophilus and Women's Proflora that have the two in it. The other lactobacilli that's been studied is crispatus, and there was a randomized placebo-controlled trial. They did it intravaginally, and the recurrence rate was 15% versus almost 30%. Another one in 2006 looked at crispatus, and some of these studies are older because they're just not doing these studies anymore. The one thing is they can't control, there are certain brands that work better than others. And that's what I had learned in my fellowship. And I actually, when I actually recommend brands of nutraceuticals, I recommend certain brands, because some of these brands have been studied and don't have what they say in it. So we have to repeat some of these studies that are kind of equivocal. We need to repeat them with the brands that say what they have in it. So Elpis crispatus actually is highly adherent to the epithelial cell, so then the E. coli kind of goes out. And then those are the two products that have the lactobacilli rhamnosus and reuteri in them. Next slide. So there's definitely a role in prevention. You don't want to give too high doses because it can cause diarrhea. And this is looking at vitamin C. Vitamin C acidifies the urine. 100 milligrams daily decreases UTI rates, 30% versus 12.7%. There was one case control study, a very early study. Amounts weren't noted. And so I don't really look at that, but we need to actually study some more because that's one of the prophylactics against urinary tract infections is vitamin C. Next slide. D-mannose is a sugar found in fruits. It's not broken down in the bloodstream, but it does concentrate in the bladder, and it basically binds the pili that binds E. coli. So then E. coli can't bind to the uroepithelium, and it comes out in the urine. They actually pitted D-mannose against Bactrim and found that they're both the same as far as efficacy. Prolonged high doses. So what happens is it's 500 milligrams 4 times a day for 3 days, stop. Prophylactically, it's 500 milligrams a day. You don't want to go any higher because, of course, for long periods of time because of nephrotoxicity. Next slide. Go back. Cranberry is probably the largest, the most studied for urinary tract infections, and it's used for prevention. And that's because of the content of proanthocyanidins. Now that inhibits the bacteria from going to the epithelial cells because that cranberry binds to the epithelial cells as opposed to binding to the pili. This whole moderate interaction with warfarin, it is possible, but you're not giving so much in order for it to create an issue with bleeding. You want to make sure that the products in the market have the proanthocyanidins, and use the one that's been studied is Allura. There's another one, Theracran, and there's a couple of others from Therapeutics. 25 PACs should be in the product. There's also another brand that's out, Eucora, that has 3 different, so promote, control, and target. And one of them contains cranberry and D-mannose. Next slide. Also, cranberry juice. So everybody's like, oh, drink cranberry juice. Cranberry juice is actually a decent treatment, but you want to make sure that it's close to 100% cranberry, which is very bitter. Not the preparations that are out there on the market with the sugar. Uva ursi and berberry leaf. German Commission E is actually the equivalent in Germany to the United States Pharmacopoeia, and it's approved those for treatment of urinary tract infection. You only want to do essentially only 1 to 2 weeks at a time, less than 5 times annually, because it can cause hepatotoxicity and death if you do too much of it. It turns into hydroquinone, which then alkalinizes the urine. But basically, I mean, it can help, and that's something that I reserve as kind of a last resort. It's not safe in children or pregnancy either. Next slide. There's some in vitro studies looking at berberine, which is from traditional Chinese medicine, which inhibits E. coli adhesion. And so that could potentially be a treatment, especially with these recurrent urinary tract infections where there's no antibiotics that are helping and you have to admit them for IV. I would never use golden seal. It's basically, there's a concern about overharvesting and the populations. And so it's going to be extinct. So we don't use it. Marshmallow root, I love. It acidifies the urine. It actually has some antimicrobial properties. And essentially what happens is the bacteria slips out. I use that quite a bit in my recurrent UTI patients. You want to make sure if they're taking it though, they take it not within, but outside of 60 minutes from taking any other pills, because it actually coats the mucous membrane. So it can coat the mucous membrane of the stomach to decrease digestion. Echinacea is something that is an immune stimulator. So that's just the immune system. Slippery elm works similar to marshmallow root, and that's a lozenge. And then you have your diuretic like dandelion. And then garlic is anti-inflammatory and antibacterial. Next slide. So kind of the things to consider in the management of medications or nutraceuticals, goals, expectations, having the patient realize, especially when they take the PCS questionnaire and they just think that pain is so catastrophic that nothing's going to help. Remember, metformin does deplete B12, which can cause neuropathy. Proton pump inhibitors deplete magnesium, which can actually contribute to spasms, especially in the Northeast. And even, patients use sunblock, vitamin D, insufficiency or deficiency is an issue. CoQ10 depletion from statins can lead to musculoskeletal cramping. Make sure if they do any type of these supplements, the minimal amount that's needed to help them, that's what they use. Some patients come in and like, oh, I'm taking B6. I'm like, what for? Oh, well, they told me that it'll help with the bloodstream, et cetera. I'm like, well, if it become toxic, it's neurotoxicity and it's irreversible. So if they think it's a B6 issue, if they're deficient, that's a different story. B complex is better because it has kind of the minimum, the recommended daily allowance of the B vitamins. And just remember that if they do come in with some of these herbal medications, do due diligence because some of them can be harmful in high doses or even long-term. Next slide. So this is kind of some of the where to go for information. You can take a picture of the slide. I can actually share this. Really important to do due diligence because you're going to see more and more patients on these nutraceuticals and doing some of these things. Next slide. These are all the references. And there are some in the actual slides as well. Next slide. So I know this was, it's a lot, and I can actually give one lecture on each of these topics. I was just trying to summarize it all to try to give you a gist. And honestly, the key is just to find out exactly what's going on, especially with some of these difficult diagnoses. And there are some general things that can be done regarding some of the medications they're on that can be contributing to some of the diagnoses that we see. So I appreciate your time. Thank you for inviting me, and I welcome your questions.
So Karolynn, I don't know if you can you see me at all? It's
yes, kind of.
Okay, good. Okay, all right. So, so thank you for a wonderful talk. You covered a lot of ground. And I guess one of the things that struck me with your talk is something that patients ask me a lot about are cannabinoids. And I was just wondering whether, how you think that fits into addressing any of these tough problems that we have to treat.
Yeah, so the problem with, cannabinoids, there's with THC and without, right? So, hemp and the cannabinoids that without the hallucinogens, actually, there are some studies looking at pain and spasms because it does work on those receptors. It helps for sleep, especially with the THC, when you do the oral preparations. I actually will send it I wait until I think I'm going to need something stronger, thinking I don't want to give them opioids before I send them to like a practice that actually dispenses this, because they do have, THC is something that you can't give, especially to patients with certain professions, like they just can't do it. Mm-hmm. The regular cannabinoids, the problem with the cannabinoids, you have to get the right brand. And I'm talking about without the THC, right? So you have to get the right brand. Topical works well, but sometimes it doesn't work on some of these patients. So it's just a question of, I honestly, in my opinion, just seeing it, I think it works better with THC. But again, THC is a hallucinogen. And so there's the problem there. So I think we definitely need more studies on that. And I know, people are doing a lot more studies, and there's there's actually like these cannabis tours to kind of learn, and where it gets grown is also better, like say the California grown versus South, et cetera. So we definitely need more studies, but cannabis is something that works well with spasms, works well with sleep, works well with anxiety. It's just, what doses do you use? And that's the question. And who controls those doses?
So on the chat, there's a question from Eric Helms. Any comments on turmeric as a treatment for inflammation, pain, and are there perioperative considerations for patients who are taking it?
So turmeric is a wonderful anti-inflammatory in high doses. Oh, first, you have to be careful in those patients who have reflux. In high doses, you want to be careful with bleeding, but that's one of the things I'm trying to actually study as far as ERAS, because it's an anti-inflammatory along with zinc and magnesium could potentially help for pain control. And so the studies out there for turmeric and, the anti-inflammatory diet and pain, especially when you're using it, you're taking with pepper and a fatty meal, because it digests. If you just take it alone, it does not, it only works in the GI tract. So you have to make sure you get something that helps it to digest. And it takes time. So with turmeric, it takes a good 6 to 8 months of continuing to take it in order for it to really make a difference in decreasing inflammatory markers and decreasing pain. You want to use it as an additive.
So
did that answer your question?
It does, or I
Okay.
assume.
I hope.
So it wasn't my question. So, So if anybody has any other questions, feel free to unmute and ask away.
You're welcome.
So. All right, so so I think this may draw the evening to a close. I know that Bill had talked about having our cocktail hour. I actually was working out while listening to Karolynn, so I just finished my glass of water to rehydrate after working out. I do want to thank Karolynn for giving us such a comprehensive talk. And just as a reminder to everybody, if you have anything that you'd like as a subject for future talks, please let us know. Either send Bill an email or send me an email, and we'll line up speakers, and really appreciate people signing on, and hope you enjoyed this evening. So thank you.
Thanks so much.
And and I guess one last thing, maybe for alumni relations, recordings for this are going to be available, correct?
Yes, recording. Everyone will receive a link to this recording tomorrow in your email, and it will also be available on the Jefferson Alumni YouTube channel.
Okay, wonderful. All righty. So I hope everybody has a wonderful evening. Thank you.
Have a great night.
Thank you very much. Very good.
Take care.
Good night.
All right.